Good morning in Washington and good afternoon in Nairobi. Good afternoon. Hello in Nairobi. Hello. Good afternoon. All right.
There they are. Good.
That took a while. And welcome to the Woodrow Wilson International Center for Scholars. My name is Jane Harmon. I've been here for about 3 months as the successor to Lee Hamilton, and in that time we are building what we call Wilson 3.0. Wilson 3.0 is the new modern Wilson Center, and obviously part of Wilson 3.0 is new modern technology. And Jeff DeBelco just told me, or I think our sponsors told me, that they wanted to do this kind of conference by international technology less than a year ago, and we didn't have the capability. Well, now we do. So Wilson 3.0 means that we can do what we've always done, but we can do it better and faster, and we can do it all over the world simultaneously. I am very pleased that we are having this global health initiative. I personally am a mother of 4 children, a grandmother of 4 children. All of them were born in hospitals with the best medical treatment available. And I am well aware that women in Africa, especially Kenya, do not have, or most women, similar access to the access that I had. While there are some encouraging trends, I have here an article in in last year's New York Times that maternal deaths have declined sharply across the globe. There are some encouraging trends. They're not encouraging enough. The decline in maternal mortality has been over 34%, but there's still a long way to go. And as I understand it, there are at least still in developing countries 350,000 deaths for pregnancy-related reasons, and many more pregnant women suffer from infections, complications, and other conditions that jeopardize their health. So, an overwhelming majority of these deaths are avoidable. We can increase access to quality health services and can scale up family planning services to prevent unwanted pregnancies and delay first pregnancies. Before I left Congress, which was March 1st of this year, my good friend Congresswoman Lois Capps of California introduced the Improving Global Maternal and Newborn Health Outcomes while Maximizing Successes Act. That's a handful, but the acronym is Global Moms Act, which would authorize greater assistance for global maternal health efforts. The Global Moms Act would create a comprehensive strategy that better coordinates our efforts on the ground in the countries where women need our help most. And last year, I think you're all aware, Secretary of State Hillary Clinton renewed a commitment of $63 billion for the Obama administration's Global Health Initiative, which includes significant resources dedicated to maternal and child health. Safe motherhood should be a basic right for all women. We have a moral obligation to make the right investments and ensure that all women, no matter where they live, have access to basic life-saving care. The Woodrow Wilson Center's Advancing Dialogue on Maternal Health is a series intended to do just that. And I want to thank the African Population and Health Research Center for co-sponsoring this event. Thank Jeff DeBelco, our very able coordinator for the Wilson Center's Global Health Initiative. And also welcome our local panelists, Nahid Mata from USAID, and John Townsend, who's Vice President of the Reproductive Health Program for the Population Council. And finally, I just want to say this. It is our intention at the Wilson Center to not do more programming. We have 800 programs a year, but to focus our programming on the key issues important to people in the world and relevant to the policy debates going on certainly in this town, but also in parliaments and government councils around the world. And obviously, when you think about that, maternal health has to be one of them. If we're leaving our planet to future generations, those need to be the healthiest generations we can possibly generate. And how do we do that? We have to worry about global health, maternal health and infant care, and that's what this conference will do. There will be a follow-on conference in September. We're not just hitting these issues once. We're going to come back to this issue because it's so important, and I now want to say again thank you to all of you for coming. Thank you to our sponsors and panelists. Thank you to the folks in Nairobi, and I'm turning this event over to Jeff DeBelco. Take care.
Thank you very much, Jane.
Thank you, Jane.
Thank you very much, Jane. It is a distinct pleasure to have you join us this morning and have you join us here at the Wilson Center and take us into, as Jane said, a Wilson Center 3.0 era, which will do exactly, one of the things it will do is exactly what we're trying to do today, which is make the conversations we've had at the Wilson Center more than just about what's in the room. It's really important what's in the room and who's in the room and the conversation we're having here, but really availing ourselves of all the various technologies to bring in the expertise that we'll hear from and the perspectives we'll hear from Nairobi today, that others can view in the live webcast and collaborate with our excellent multimedia and TV team here at the Wilson Center. So this can be something that through a variety of outputs, everyone can have a greater opportunity to access and take part in these important conversations. So we've entitled today's session, Maternal Health Challenges in Kenya, What New Research Evidence Shows, and we're very fortunate to really be kind of piggybacking on what has been a very active day of discussion, a whole day discussion in Nairobi, done with our partners in this effort, the African Population Health Research Center. It's been terrific working with them. I should say Jane was very kind in thanking me, really Kaylin Ostrowski, who's over there in Nairobi, and colleague Kaylee Ober, and the partners, the African Center, are the ones who deserve the credit for making this happen and are the real brains behind the project. To give you just a quick sense of what we'll do, how we'll do this, because it is a little different. We will hear from 3 speakers in Nairobi, and then we'll have 2 respondents here in Washington. I'm not going to spend a lot of time on their bios because it would be much more interesting to hear from them, but you can reference those in the materials that you picked up. This discussion on maternal health, as Jane has alluded to, fits within a now going well into its 2nd year of focus here at the Wilson Center under our Global Health Initiative, slightly more modest than the Obama administration's Global Health Initiative. But in our Advancing Maternal Health series that is very generously supported both with resources but also even as important, if not more important, intellectually with Maternal Health Task Force and Tim Thomas. It's terrific to see Tim here, and Sarah Craven from UNFPA and Blank, who I hope from Maternal Health Task Force is watching online as well. It has been a terrific partnership with them, as well as, I should say, USAID has provided technical assistance all throughout the process. So it's been a real partnership and a conversation in what last year was a monthly series, and this year has a series of meetings, but particularly highlights this overseas partnership as well. So I will dispense with any further upfront details so that we can get on with the discussion. And so if our speakers can, the camera can focus on the podium there a little more. I'll just, as I said, very briefly introduce our speakers, and I think we'll just go in the order that we have listed on the agenda. Lawrence Ikamari is the Director of Population Studies in the Research Institute. He will be followed by Catherine Koyo-Batungi, who is the Director of Health Systems and Challenges at the Africa Population Health Research Center. And finally, Jeffrey Mumia Osaji, who's a professor at University of Nairobi, will give presentations there. And after those 3 in a row, we'll have some comments, as I said, from Dr. Nahid Mata, who's a Senior Maternal and Newborn Health Advisor, U.S. Agency for International Development, is back, I guess, just within a couple months. She graced the stage for an excellent panel on an Egyptian discussion on maternal health just a little while ago. And then John Townsend, who's, as we heard, Vice President of Pop Council. So if Nairobi, if it works for you, I would love to have Lawrence Ikamari make the first set of remarks. Sir, the floor is over to you in Nairobi.
Good morning, Washington. My name is Geoffrey Mumia Osaji.
Oh, Okay, they switched it on the order. Okay, go ahead. Go ahead, Professor. We're flexible. Whatever works for you all in Nairobi.
There was a slight moderation on our program. I'm the moderator for today. First of all, I want to convey my greetings to Madam President, the panel, as well as the plenary at the Woodrow Wilson International Center for Scholars. As I said earlier, I was the moderator for today's session, and today's topic was maternal health challenges in Kenya. What new research findings or research evidence shows? My presentation earlier highlighted the status of maternal health care in Kenya. I observed that although there have been improvements in the recent past, the status of maternal health care has not met the required international standards. Therefore, there are numerous challenges, and this is why today's meeting was held in order to come up with the solutions that will help us to meet the challenges that we are facing. In today's meeting, we were able to have presentations by Dr. Lawrence Ikamari, and his presentation was on the state of maternal health in the rural context. The second presentation we had was by Dr. Catherine Yegotungi, and her presentation was on the state of maternal health in the urban context. We had another presentation by Dr. Margaret Meme on the human rights approach to maternal health care in Kenya, which gave a different overview of the maternal health care in the country, which was different from the statistical as well as the medical approach. After the presentations, we went into plenary, and the plenary was divided into 3 groups to reflect on 3 broad questions. The first broad question that the groups reflected on was, what are the knowledge and capacity gaps to improve maternal health in urban and rural settings in Kenya? And to help us reflect on this particular question, we had 2 sub-questions. The first sub-question was, how can policy makers, civil society organizations, development partners, and other players in the health sector coordinate and improve human resources for maternal health care in Kenya? The second sub-question that was asked is this: what population groups should be involved in setting priorities for maternal health in Kenya? In other words, what maternal health priorities should be set in Kenya? The second broad question that was discussed today is this: what are the policies and funding priorities that are required to increase the uptake of antenatal and postnatal care? This question was pursued using 2 sub-questions. The first one was, which development sectors should be involved? For example, should we involve the transport sector, the communication and technology sector, the agricultural sector? The last subset of question in this particular broad question 2 was this: where is the opportunity for the Kenyan maternal health community to forge effective and efficient collaborations? Then the last broader question that the panel today discussed was this: what is needed to increase education and distribution of midwives in Kenya? What is needed to increase education and the distribution of midwives in Kenya? In other words, how can the challenges facing midwives, such as training, recruitment, retention, and remuneration, be addressed? The sub-question to this particular broad question was, what are the policies and funding priorities that are required to increase the uptake of antenatal and postnatal care? When the plenary reconvened, they came up with a number of points that shall be explained by the key presenters of today. So I pass over the microphone and invite Dr. Lawrence Kamari to shed additional light on what we discussed and came up with today. Thank you, Dr. Kamari.
Yeah, thank you very much, Professor. Can I just jump in for 1 second? This is Jeff DeBelko in Washington. Is it possible for Dr. Ikamari to make the address from the table that has the video conferencing? I think the microphone there feeds directly in, and the audio quality for us will be much better, and I think it'll be much better for our online viewers as well, if that's possible. Sorry to make you move, sir, but I think the upgrade in the audio will be worth it, at least on our end. Sorry for displacing you.
Good morning. Good morning.
Good morning.
Good morning, sir. And when the cameraman has a chance, we'd love to see you as well, sir. Brilliant.
There he is.
Terrific. Thank you, sir.
As our moderators indicated to the audience, my discussion focused on the status of maternal health in rural Kenya. In the presentation, I did give a background regarding the Millennium Development Goals that are directly or indirectly related to maternal health. That is Millennium Development number 4, number 5, and number 6. I also did look at the projects or the programs that are necessary to improve maternal health, both in urban and rural Kenya. And then my next discussion then focused on the status of maternal health in rural Kenya. I focused on looking at maternal mortality, and the statistics that we did indicate, we did give, showed that maternal mortality in rural Kenya is still very high. We are talking about maternal mortality ratio in excess of 500 per 100,000 live births. And there are significant variations in the country across different regions. I also did indicate that fertility is still very high in Kenya, particularly in rural areas. Currently, the estimates for total fertility rate is about 5.2 children per woman, which is still very high. But at the same time, there are regions within Kenya which have very low fertility, almost to 2 children per woman. And again, this is, there are so many reasons why fertility is still high in the country. We did look at, for example, the issue of that women start childbearing very early, and marriage is almost universal. And as I also showed later on in my presentation, that there is limited access to family planning, and also the fact that infant mortality is still very high. So all these things fuel, sort of, in a way, contribute to high fertility. I also looked at the issue of infant and early childhood mortality. And all the statistics that we did give show that infant mortality, although has been declining over the last couple of years, it is still fairly high. We are talking about an infant mortality of around 50 per 1,000 live births in rural Kenya. Of course, in urban areas, this is slightly lower. And in addition to that, we looked at the various variations across the country, paying attention to rural areas only. Now, from there, I looked at the issues to do with safe motherhood, the uptake of antenatal care. We indicated that in rural Kenya, there is high coverage of antenatal care. Nearly all women who are pregnant seek antenatal care. Almost 92%, 90% of all the women who gave birth 2008, 2007, 2008, and 2009, who were interviewed in a national survey, the Kenya Demographic and Health Survey, did seek antenatal care. However, the majority of them seek antenatal care during the second trimester. In fact, almost for 60%, 62% or thereabout of those women did seek antenatal care during the second trimester. There are also a couple of them, about 20%, who sought antenatal care in the third trimester, when actually it's late for them to enjoy the entire the benefits of early antenatal care, seeking antenatal care. In terms of delivery, my presentation indicated that the majority of Kenyan women in rural Kenya give birth outside health facilities. In fact, at home, without the benefit of skilled birth attendants. And in the survey I referred to earlier, a number of women were asked as to why they did not go to the health facilities. And quite a number of them, nearly 42% of them, indicated that the facilities were too far at the time they gave birth, or that transport was not available. And there was also a sizable percentage of women who reported that they didn't see the need to seek delivery at health facilities. So these are some of the reasons that the women gave. I also looked at the issue of family planning. As you all know, that family planning saves lives. And the situation that we have in rural Kenya is that the uptake of family planning is still very modest. The prevalence is still very modest. About 35 to 40% of currently married women are using modern methods of family planning. And that there is still some unmet need for family planning in the country, and particularly in rural areas. We also looked at the issue of HIV/AIDS. We indicated that the current survey results show that nearly the prevalence among rural women, HIV/AIDS prevalence rate among rural women in Kenya is about 7%. And that compares compared with about 8% among women in urban areas. But because the majority of the Kenyan population live in rural Kenya, nearly 75% of the Kenyan population lives in rural areas. the burden of HIV is really felt in rural areas. And in way of recommendation, because of the limited time we had, I recommended that rural women in Kenya need to have increased access to maternal health services, that including family planning, including institutional delivery care, including postpartum care, including good follow-up after delivery. So I would like to end there for now, and I would like to welcome, maybe to leave my colleague out to welcome questions. Thank you very much.
All right, thank you, sir. Yep.
Good morning and good afternoon. I'm Catherine Choutunji from the African Population and Health Research Center, and my talk was about the state of maternal health in urban centers in urban Kenya. But I started off with a broad overview of the situation in terms of maternal health, basically how Kenya is performing regarding MDG5. And the broader picture shows one either of stagnation or actually retrogress rather than progress. And this is evidenced by the fact, for instance, that skilled and tended delivery has not changed since 1993, from around 45% to around 44% in 2008. And other indicators like teenage pregnancies, which are a reflection of the failure of either family planning services, show about 21% in 1993, which has fallen slightly to about 18% by 2008. And issues, maternal mortality rate, 414, 2003, right now 488, according to the last DHS of 2008. And despite this, the interventions that are supposed to address maternal health are well known. Increased access to family planning, increased access to safe abortion services, skilled health workers, health facilities that are accessible, as well as referral systems that work. And when you look at how Kenya is doing in terms of these programs or interventions that are supposed to work, we find that, for instance, the unmet need for family planning is around 26%, which is not far from the sub-Saharan African average. We find that about 39% of all pregnancies are unintended, and 40% of these end up in abortions. We find that for every 10,000 population, we have one physician. And based on the averages from other professions like pediatricians, we know that almost 65% of the physicians in the country are based in Nairobi. So when you remove Nairobi from the numerator, then the skilled physicians per population is in the decimals. It's less than 1 per 10,000. And we find that there are health facilities that are few and far between, that are not easily accessible, and that referral systems are quite weak. Now, the part of my presentation focused on a recent paper from Montagu that was published in PLOS ONE in March this year that showed where poor women deliver in developing countries. And this was an analysis of DHS surveys over the most recent DHS surveys that were available in different countries. And there were about 9 African countries represented in this analysis. And some of the statistics show that if you look at the poorest quintile of women, almost 78% deliver either at home or either at their own home in another person's home. And this is compared to only about 22% in the wealthiest quintile. And when you look at the use for public facilities, only about 18% of the poorest women are using public health facilities compared to 54% of the wealthiest quintile. And out of these women that don't use health facilities, the ones that have home-based deliveries, 54% of them are delivering either unattended, that is alone, while 41% are using traditional birth attendants. And when you go to the richest quintile, we find that 40% of the 22% that deliver at home are unattended, while 33% are using traditional birth attendants. Now, looking at when the women who delivered at home were asked the reasons why they delivered at home, 67% of the poorest women say that it's not necessary. Either the husband thought it was not necessary, or the family thought it was not necessary, or the woman herself thought it was not necessary. And when you look at the 22% of the richest who delivered at home, 75% still say that they don't think it was necessary to deliver in a health facility. So what that shows is that there are actually other reasons beyond cost and access as to why women don't use facility-based services for delivery. And actually, the percentages for cost were about 7%, and the percentages for access were about 25%. Now, going to the urban context of what's going on within Kenya, my emphasis was on the fact that there's both, much as we appreciate the rural-urban divide that exists in most health indicators, the urban-urban divide is just as important. The fact that there are huge intra-urban differences that need close attention. And in other health indicators, these urban-urban divides have been reflected in the fact that the urban averages are becoming either closer or worse than rural averages. And this is evidenced in the most recent Kenya Demographic and Health Survey, where infant mortality in urban areas for the first time is worse than infant mortality in rural areas. Other indicators that are showing a similar trend include the teenage pregnancy rate. For the first time, the teenage pregnancy rate in urban areas is worse than the teenage pregnancy rate in rural areas in Kenya. Now, when you break it down, if you look at an analysis of the DHS data focusing on the urban population, but then breaking it down by wealth, so looking at the poorest and the richest in urban areas alone, shows also gross differences. For instance, the total fertility rate in the poorest quintile in urban areas is 2 children more than the richest quintile in urban areas. While for teenage pregnancy rates, there are 3 times more teenagers that are pregnant among the urban poor compared to the urban rich. Now, apart from the issues regarding the urban-urban divide, I touched briefly on measurement issues. The fact that much of the statistics we're using are based on demographic and health surveys that come around every 3 or 5 years, and the fact that much more investment is needed in systems that measure maternal health outcomes on a more routine and a more regular basis, so as to inform decisions and programming within countries. I talked about what is being done. It's not all gloom and doom in urban areas. There's a very big urban reproductive health initiative that is currently being implemented in Kenya, among other countries, that is trying to improve access to family planning to especially the urban poor, recognizing the fact that family planning is the first step to safe motherhood, because a woman that doesn't get pregnant is unlikely to die from is unlikely to suffer the consequences of pregnancy, at the worst, which include maternal death. Now, some of the things we discussed in the group sessions, the questions that we had as a group were the third set of questions that where we were supposed to discuss how to increase the education and distribution or deployment of midwives, and how variables such as training, recruitment, retention, and remuneration can be addressed, and the policies and funding priorities that are required to increase uptake of both antenatal and postnatal care. And we had a fruitful discussion for about an hour, and I'll just summarize our deliberations in 3 key areas. The first one was the need for integration, not only at activity level, where the midwife or the nurse is told integrate, 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 when programs are still parallel and when funding mechanisms are still parallel. So integrations need to start at the bottom, but it also needs to be considered at the top in terms of funding priorities into one basket of maternal health issues. For instance, the malaria program, malaria in pregnancy, the PMTCT, all these are maternal health issues, so there should be a funding mechanism for maternal health, not for separate programs that sort of overload the system and end up in duplication and inefficiencies. The second issue was to rethink the training strategies, focus more on pre-service training and less on in-service training, not only because it's expensive, but it's also time-wasting. It takes away health workers from their work, and therefore ends up creating other obstacles to care that could be easily addressed. And training should focus on training needs assessments that are done at national level, but also training needs to be monitored in the form of training management information systems, so that some people don't get overtrained and are taken away unnecessarily for long periods from their time. The other last issue that we discussed was to have some system of performance-based incentives that are linked to funding mechanisms. For instance, there are good examples of a successful program, the output-based aid approach, that has increased uptake of both antenatal and delivery services. So if performance of midwives and doctors could be linked, incentives could be linked to their performance through such funding mechanisms, then the hope is that the uptake for maternal health services would improve. I'll stop there and welcome questions and comments. Thank you.
So if I have it correct, we have, then we'll turn it back here to Washington for discussions, or was Professor Hasanji going to make any further remarks? I just want to make sure we don't cut anybody off.
Yeah, thank you very much, the chair of the panel at the Woodrow Wilson International Center of Scholars. The only additional remarks I will make relate to the group work that was done this afternoon, and I would like to just add a little clarification on what the groups discussed. Some of the deliverables in the group work include, in group 1, for example, the fact that there was need for clarification of the position of user fees in health facilities in Kenya. Participants felt that the question of user fees has affected negatively the gains in maternal health for women. They also made the following observation, that there is a need for political goodwill to enforce and also legislate relevant legislation to ensure that maternal health care services are not only efficient but are also effective in this country. There was also need to improve what is known as level 2 and level 3 health facilities. These are the facilities that are below what we normally call the referral hospitals, the large national referral hospitals. Those hospitals that are at the lower level are referred in this country as level 3 and level 2. So if they are strengthened, then most of the cases that we have had that have contributed to mortality, the high mortality figures that were given today, will also be reduced. Other issues that were raised in group discussions include the need to preserve the training of midwives and also to scale up their training. And the question of midwives is also linked up to the question of traditional birth attendants. Now, the discussion that we had today revolved around the question of whether traditional birth attendants and their position in the health system should be scaled down or stepped up. And it was noticed that, or it was noted that they still play a critical role, especially in rural areas, but they require skills. So there is need to strengthen systems and mechanisms that not only recognize their role, but also ensure that they are structurally linked in a good cohabitation with the formal systems. It was also noted in the group discussion that men who've had, in some cases, a poor record of support for maternal health care should be involved in maternal health care provision. And this was emphasized with respect to the need to raise awareness, especially in rural areas, where it was felt that sometimes men have neglected their husbandry responsibilities. The question of investment in healthcare has been a big problem in this country, and participants were keen to lay emphasis on it, that the government and other players need to increase funding allocation. It was pointed out that the Abuja Declaration indicated or advised governments in the African continent to increase health allocations up to 15% of their budgets. But it was noted that Kenya only allocates between 6 and 8% of its national budget to health. So this means that the government is performing below par. So it was emphasized that government should be goaded or forced, if they cannot be convinced, to increase or scale up their funding of health facilities, and especially with respect to maternal health care. The question of integrating health services and health systems in the country, and especially strengthening the health supply chains to ensure that health facilities, whether they are hospitals, health centers, or clinics, they have good facilities, was also emphasized. And a key challenge which the two speakers who spoke ahead of me emphasized was the question of human resources. Many skilled health service providers have left the public sector to the private sector because of poor remuneration, poor terms of service, and also poor facilities and working conditions. So it was recommended that the public sector, especially the government-run health service centers, should think of the need to improve not only their facilities, but also the terms and conditions of service for their health service providers. Similarly, there was a question of which of the sectors should collaborate in enhancing maternal health care services in the country. And some of the sectors that can be brought on board to collaborate, because it was noted that maternal health care services are not in isolation. They are part and parcel of the whole society, and all sectors of society should play their role. So improving the transport systems in Kenya, improving the agricultural production, as well as the communication and telephone networks, will enhance the health delivery of effective and efficient health care service in the country. I mentioned something about the legal frameworks, which I will not repeat, but I want to reiterate the fact that there is need, as the groups discussed and noted, for multi-sectoral approach in not only planning, but also in implementing and monitoring the health projects in this country. There are a number of other issues which the groups discussed, but let me pause a little bit to allow response from Washington.
Terrific. Thank you very much, Professor. We appreciate that that additional characterization of the highlights from the breakout groups, because I know you met in different formats. So thank you very much. I think perhaps what I'll propose that we do is hear from our two experts here in Washington, and then we can have a group Q&A which brings all the insights together. So I'll turn the floor over to Dr. Nahid Mata, who, as I mentioned, is the Senior Maternal and Newborn Health Advisor at USAID, and she and John Townsend will make some remarks that in part play off the presentations, but also, of course, bring their insights to these issues as well. So,
okay, thank you very much. As Jeff mentioned, I work at USAID, the Global Health Bureau, the MCH division. So most of my talks involve working with missions to support ministries of health, improve and strengthen the maternal and newborn health programs. And I have experience working in several countries. I'm not necessarily a Kenya expert, However, I have been involved with the USAID and the mission in developing the Global Health Initiative strategy that's been mentioned, which focuses on integration among US interagencies and sectors, and have been involved in the BEST strategy, which is a new focus for USAID to integrate family planning, maternal and child health. I was really delighted to hear summary of the presentation and discussions by our speakers. And to be honest, they have stressed on several of the things that I wanted to stress as well. So I will actually highlight the two questions we're supposed to ask. What was good for us to hear from what you said, and what are the gaps that we might consider? And it's important to say that all the issues that is being discussed in Kenya is very similar to many other African countries and sub-Saharan countries. So I was delighted to see that family planning is a key component of what's discussed. I come from the maternal health background, so at one time we thought the family planning team are really approaching on the funding that comes to maternal and child health. Years and years we realized that family planning and family planning efforts and addressing unmet need contribute to the maternal mortality that we want to achieve. So for any maternal health person speaking, we'll put family planning as number one. And as been mentioned, we still have high unmet needs in family planning. I think very relevant to that is the young girls, I would say, or women entering childbirth. I think the women from 15 to 19 contribute a large number of the maternal mortality in Kenya and many other countries. So I was glad to see family planning one of the focused area. The other important thing that was mentioned, and we cannot be neglected in the Kenya situation, is the skilled birth attendance and lack of institutional availability, access to institution delivery, whether the woman does not perceive she has to go, and whether there are lack of staff at those facilities, especially the health center level. I'm sure the dispensary probably would not have, and then the first and second referral level, which might not have all the equipment and environment to support the midwife if she's there. I have read some statistics to say it's not lack of doctors and nurses in Kenya. There are probably 60% of the registered, only 60% of the registered doctors and nurses are actually deployed. So this is a big issue. I think more than one person highlighted that we have to address this area, the actually deployment, the distribution, high numbers being stationed in Nairobi, so it's distribution, deployment, retention, and incentives to keep them. So I was pleased to see some discussion on pre-service training because that's would allow for more investment, long-term and sustainability, and maybe task shifting could be considered. That what cadre, what's the duration of training for the midwife? If it's, I'm not sure how, what's the years for a midwife to be qualified to deliver, whether anything could be done in this area. Another thing that was mentioned and by one of the speakers is the cross-sector coordination. Specifically mentioned between health and maybe communication, maybe transportation, and definitely education. And I would say whether agriculture, because nutrition and food security is very much linked to maternal and newborn health and child health mortality, and maybe labor force and maybe finance. If we want to change the payment scale to encourage midwives and nurses to continue working with the public health services, I think this is an important area that maybe you have to be discussing. Some of the things that I think we have to always mention when we talk to maternal health, and it's included in the paper, is not neglecting newborn. We now talk about maternal and newborn as a dyad. When we do any training, even the famous EMOC, Emergency Obstetric Care, is now called Emergency Obstetric and Newborn Care. So I want to make sure that while we're addressing maternal health, we're not neglecting newborn, and it's easy. If you're doing training at all levels, if we add newborn to the maternal health activities, that definitely would be cost effective. The other thing that was mentioned, we have mentioned across sector coordination, and I think Dr. Catherine mentions maybe the within sector. And we as AID have been trying, and other donors as well, to let go of our vertical programs because we want to show results. We have money coming for HIV, and we have money coming for maternal health, and we have to show results related to this specific technical area. Really, with the Global Health Initiative, there is a strong push and recommendation for integration among the health sectors. So we're talking about any opportunity to see the mother, even she's coming for the immunization, we have to provide family planning counseling, address nutrition. If she's coming for routine antenatal care, of course, we have to provide PMTCT services and check whether she has her HIV status checked and then followed up when she delivers as needed, and so on. Family planning has been always vertical to maternal health, as I mentioned earlier. We're now working together. We cannot ignore the importance of addressing the family planning needs postpartumly. Some women come to those facilities, completed the family size, have 8 kids already, and maybe have, and I've seen it in several areas, including rural Egypt. She didn't want the number 6, 7, or 8 baby, but no, and she has diabetes. She will probably can get pregnant again. She's still 35, and she could die in the next pregnancy. No one talked to her about maybe a more permanent method of family planning. So integration within the health sector, this is what this best document that USAID across many missions are developing, and Global Health Initiative, it's really stressing the integration and the missed opportunities for not integrating. Another area that, and I'm sure you agree with me and you're working on that, but we are saying as AID, we are helping you because all the documents that AID developed was meant to be developed with the government. The government is leading those programs. We are at the back seat as AID, and we ask missions when they develop any of their strategy and documents to have the government lead those programs. And we recommend, and the government, of course, and I can see the professional and experience level is high. Kenya is very much known in exporting, actually, expertise outside Africa. So we depend on partnership work between missions, government, and other partners. Very few, I have maybe just few things to mention that is worth discussing. Role of private sector, I didn't hear it. I think private sector constitute around 40% of the services, and they probably are doing a great job. Faith-based organization, we don't know about the quality of services. I think we have to address that, and they may be accreditation, thinking of accreditation and continuous medical education. I come from the experience in Egypt when many women were coming to deliver in the facilities, and unfortunately the mortality is happening in the facility because the physicians and nurses are not trained to properly manage complication, and actually a little bit, of course, environment, whether the supplies, the blood, and all of that. So we don't want to be pushing the woman to the facility, and the facilities are not ready. And thank you for raising this as well. You wanted the level 1 and 2 hospitals to be improved, and this comes together. One area that as well, I'm sure it's happening in Kenya, but not mentioned, the role of the community outreach program, because if the woman is saying that we don't think we need to do a facility, then something could be worked at the community messages, community mobilization, and maybe home visits during ANC period to advise on birth preparedness and the role for institution delivery. My last word is something that USAID is stressing, and we think it's not the reason for the women not going to facility, but studies after studies are showing that it is. Women are subjected to disrespect, abuse in the health facilities. There is lack of consent. We not tell them what they're going to do, whether it's a procedure or not. There is lack of confidentiality and privacy. There is humiliation, the discrimination, physical abuse, abandon of care, and detention unnecessary in the facilities. So we're working with governments and partners to try to address, because maybe this is the unexpressed reason for why women are not going to the facilities. Thank you very much.
John, the floor is yours.
Terrific. Well, welcome again, and thank you to our colleagues and panelists in Kenya, Jumbo, Asante Sana. This is really a critical theme, and some of my comments were going to be direct more to the Washington audience than the Kenyan audience. The use of evidence to shape policies and procedures for reducing maternal death and morbidities is critical, and we're at a critical stage right now. But evidence in the absence of context and a clear political strategy to address this is challenging, and perhaps a poor segue into actually policy engagement and implementation and financing. So I'm going to try to pull some of these things together. The first thing is the Kenyans have obviously done a great set of analyses, both in terms of policy and in terms of population outcome. The National Reproductive Health Strategy has been around for 13 years. The DHS is recent and shows some progress in some areas and some weaknesses in others. And the Kenya Health Service Provision Assessment, which was 2010, looked at facilities and said, are these facilities ready to provide quality at a level that's required? A little bit more context. Kenya is a population of 40 million, mostly rural. And there are about 1.5 million births a year currently, and maybe 3,000 cases of fistula, obstetric fistula, that are identified. So kind of thinking about that magnitude, at the current rate of growth, which is 2.7, with every woman giving on average 4.6 births, having 4.6 children during her lifetime, every woman has about a 1 in 39 chance of dying in childbirth. Disability is 10 to 20 times, or morbidity is 10 to 20 times that amount. But because of the population growth, by the year 2025, there will be 25% more people, and because of the young age structure, probably from 40 to 50% more births. What that means is when we're planning these things, we can't plan them on the shortfalls of today. We have to think about what is the scale of solutions that we're proposing for the 2025 and 2050, when the population will be 60% higher. With the young age structure, I said 42% of the population is below 15, which means we have to begin thinking about young people, information about sexuality and health, giving them roles for protecting themselves and their families and their partners in a way that our societies, whether it's in Kenya or the United States, haven't thought about. So we need new models. The second thing I think it's important for the group to mention, I think Nahid brought this up briefly, is the Kenyan health market is extremely segmented. So it's public, private, NGOs, faith-based organizations. Emergency contraception is largely purchased in pharmacies. And I think the issue is that only about half of services really come from the public sector. And so we have to think broadly when we're thinking about policies. So if we were going to only improve the private sector or the public sector, we would leave a lot of people out. And in fact, there are people who can't afford to pay the private sector that go to public services and their services are being subsidized. I think Catherine did a terrific job at describing some of these dynamics in urban centers. While the population is still largely rural, 4% is the rate of growth in urban areas, and so we're going to see increasing urbanization. And I think Catherine also referenced the fact that about maybe half the population may be living in something that would be called a slum. We could get back to how do we think about urban health services in places where the government hasn't wanted sanctioned settlements. Mm-hmm. In other words, they're unlikely to provide health care in Kibera in a way that might be required. So just kind of thinking about the context, we've been moving from a context of crisis of schooling, where Kenya's actually done reasonably well, to a crisis of early reproductive health. So how are we going to address these issues as this age cohort moves through? I think the evidence is that's been presented is well configured, well considered, hits all the right spots. At one point, I thought this was going to be a meeting about how we think about midwives per se, as opposed to the larger issue. I'm very pleased and congratulate the Kenyan panelists for framing this in an appropriate way. Clearly, 39% contraceptive use when you're having, the average woman's having, nearly 5 children, is a conundrum. How does this work? There's huge discontinuation. People are using it late. People aren't using it well. The information from the DHS and the health provision assessments suggest that people aren't getting the appropriate information how to use methods correctly. They aren't told about how to deal with side effects. So in terms of some of these issues, we have to think about what can we do to improve quality of care. It isn't just getting someone into an ANC clinic. We know that on average they come only once. They really need to come 4 times. How do we do that? And I think we'll get to some of that in the discussion. The issue about family planning comes down to, okay, what models are we talking about? And there was some suggestion about postpartum, which makes a lot of sense for health in terms of spreading out and delaying the subsequent pregnancy, which we know when the intervals are very short, there's increased risk for the mothers and children. And also post-abortion. We heard about a figure, I think, that one of the panelists suggested that abortion is relatively high, and it will get higher as the total demand for children goes down, and we can't hide it. This is a very sensitive issue in many countries. It's particularly sensitive, I think, in Kenya, where the press has taken this issue and batted it around quite a bit, and traditional conservative religious groups and religious groups have kind of tried to bring abortion and family planning together in a way that I think does disservice to women's health. The next big topic is actually the role of gender. I think that has to be up front, and I think we had some of that from the panelists, some about the role of men, but not sure what men should do. We clearly don't want to have men beginning to manage women's health care. But I think there may be ways in which we can frame the issue that around the participation of men in ensuring that women get the care they need, that they know the benefits of this for their own family. Many women in Kenya work in agriculture. So if they knew that actually having 2 or 3 ANC visits it would reduce the likelihood of losing labor, that may not be a love note, but it certainly is something that makes sense, I think, from a family investment perspective. The panelists also referred to equity. Equity is one of the biggest issues, and I think the analysis by Quintile, which was being framed, is really important. In other words, what happens to the poorest, what happens to the wealthiest? The wealthiest pretty much look like Cairo, New York, Rome, and New Delhi. The poorest are really out of luck. And our analysis on all these strategies is who pays and who benefits. And I think that's an important issue as we move ahead of time. Integration is a terrific issue, but when the health systems are weak, putting more burden on a local community health worker does not usually make sense. So we have to think about smart integration. How do these things move? What do we build together to get the biggest benefit for women's health? One bit of integration that wasn't talked about is integrating advocacy into this. So we know integrating services and we know about integrating data, but how do we get advocacy online with some of these same messages? The First Lady, Madam Ola Odinga, this year talked about more financial resources for maternal health, more awareness of stakeholders about the magnitude of the problem and its consequences for families, communities, the public exchequer. Education of the public about the causes and consequences, the 3 delays in recognizing the problems that relate in prenatal and before delivery, the delay in transportation, and the delay in actually, when you get to a facility, does anybody know what to do? Training doesn't always solve that, but when you integrate families, political will, and stronger health systems, you begin to see those benefits that we're talking about. She also called on the men of Kenya to play a more substantial role in protecting their sisters, wives, mothers, and so on. Terrific. I think the last but a big issue has to do with financing. Right now, northern Kenya is dealing with serious drought. Agriculture production is down. Food prices are up nearly 50%. The roads in Nairobi right now, as our colleagues there can attest, are being dug up, and the Chinese road flyovers are being developed, and that's got to be expensive, and that's important for transport in Nairobi, but it doesn't address the problems of people getting to health services in Nyanza or Naivasha. These are priority questions. Exactly what do we have to do? And there are other health issues, for example, HIV with 77% of the adult population living with HIV, malaria. I think the integration issues begin to make sense when we put these together, and I think our colleagues there have got some really innovative ideas about and some examples about how this works and where it works. I think the issue of vouchers, Kenya is one of the premier places that's been looking at demand-side financing, and they're looking at using it for putting money in the hands of women to pick their provider, whether it's public sector or private sector. And the issue of logistics is one that hasn't been quite as successful. The logistics system in Kenya, Tanzania, and many related countries it doesn't have a good track record of getting products to where people need them on a timely basis. If there are 70,000 shortfall in health staff because they're not being paid, we have to do something in our financing mechanism that creates an incentive for people to come to work, have the skills required to save lives, and to and actually be there. 78% of facilities use user fees, so there's a net transfer from poor women to the public sector. We have to begin thinking about how to change that flow of resources so the public sector provides resources to poor women so they can protect their lives, others. And lastly, my only point is, how do we move from this elegant display, I think, and understanding of the evidence to action in a political context that is demanding resources on all sides, where disenfranchised refugees from Somalia, Ethiopia, Sudan are moving into slum areas. How do we begin to think about what do we do, how do we set priorities, and how do we integrate that policy, economic, and service delivery strategies into a piece that finally delivers on the promise to Kenyan women and their families. Thank you.
Terrific. Thank you very much, John. Well, thank you to the two speakers here in Washington and the 3 in Nairobi. I think what we'll do now is grab some questions, and my colleagues have a microphone here. We'll bring that to folks. Maybe we'll collect 2 or 3 here in Washington, then give our colleagues in Nairobi an opportunity to respond, and then also respond to any comments from our panel here. And then, of course, if folks in Nairobi want to pose questions, we'll have the questions going both ways. You, Jeff, you just give me a high sign, and we'll pick up questions from your side as well. So who would like to start us off here in Washington? If we could come down here in the middle, we'll get a microphone to you. And if you could just let us know who you are so the folks online can hear you too.
Hi, I'm Quinn Libson, and I work at the Pulitzer Center on Crisis Reporting. And I have a question mainly for Catherine Kyobatungi, but I guess it's open for anyone who wants to answer. You mentioned that there are some gaps in the statistics concerning why women choose not to go to health facilities when they're giving birth. And I was wondering if you could expand on that, if there are cultural sides for the stakeholders involved, and maybe other issues keeping women from going. Thank you.
Okay, why don't we collect 1 or 2 more here in Washington. Yes, ma'am in the middle, if we could just pass that microphone back to her.
Hi, I'm Stephanie Sangling from the Pan American Health Organization. And my question is, what type of work is being done right now in the area of research prioritization? For example, how do you go about identifying, selecting, and ranking different research priorities? Thank you.
Okay. Terrific. Professor, if you could, the panel there in Nairobi, if you want to divide and conquer. Catherine, I think the first one was for you, if you would like to go with that.
Thank you so much for the questions. The issue about the statistics on why women don't want to use health facilities, the data that I was quoting actually was a secondary analysis of DHS data. And it's widely acknowledged even in that paper that the data was not, the questions were not set out to answer that particular question. So it's trying to make do with what exists, but actually a lot of research has not been, not much research has been done in that particular area. There are a few studies from mostly qualitative studies that are looking at provider attitudes, they are looking at issues of access and all that. But I think this particular paper, what it brings out is the very large proportion of women who think it's not necessary. And if I was to recommend further research, I would say, how do you unpack that not necessary? Because it could hide all manner of cultural, social, and other issues. So I would actually be more suggest perhaps a question that is open, so women can just say exactly what it is that prevents them from using health facilities, and then try to record that, rather than putting people in boxes and making them have to choose a response, because I think that's what happened that's what happened in the DHS surveys. So in terms of that, that's as far as I can respond to that. I don't know, I can take a shot at research prioritization. I think that's a big challenge that there, as the question has been mentioned about integration, and maybe I like the point about integration in advocacy. It's the same, maybe integration in research, that there are different players with different interests, different funding situations, and sometimes the research follows the money. So research prioritization actually, research is prioritized according to funding priorities. Which is a bit unfortunate, but that's the world we live in, that we have to deal with. I just wanted to mention something that Mary, I believe, raised about the role of the private sector, and I couldn't agree more. And I think this role is even much more important in informal settlements, where the private basically is almost non-existent, and the private sector is very dominant. When you look at the national averages of about 40% using the public sector, in informal settlements it's about maybe 26 or 25%. So almost 75% of health services are being offered by the private sector. But it's a sector that is almost struggling on their own and doing it their own way. So trying to find creative ways of engaging the private sector through government, because they're actually playing a big role that is supposed to be government's role. So finding creative ways, as we said, accreditation issues, support with essential service, with essential commodities like family planning or even vaccines, I think would go a long way in trying to improve the quality of care, as well as the geographical access for people, especially in informal settlements. My colleagues can take it from there.
Musical chairs.
I don't know what to add more, because my colleague has said most of it. Regarding the issue of why some women choose to deliver at home, I think there is some, we don't have much knowledge about this. All that we have is what has been given to us in the recent survey, KDHS 2009, and the analysis that my colleague and myself reported earlier was actually based on the DHS analysis. But the issues that the group here discussed, including the cultural issues surrounding birth, that there are a lot of issues that various communities attach to delivery. So there are certain cultural issues. For example, in certain communities, there are certain gifts that somebody who has just given birth is given immediately she has given birth. And when this person delivers in a health facility, she may not be given those gifts. So all these are cultural issues that may be specific to various communities, and we need some detailed research undertaken to understand these dynamics in a more detailed way, so that we can bring this evidence to bear in some of our programs. With regard to how research priorities are set, I think, as my colleague has said here, a lot of these things seem to follow money. Really, where money is, where the donors, or where there is money to take up an issue, you find research is carried along those areas. But we have a colleague here from the Division of Reproductive Health. Recently, there was a release of guidelines. I think guidelines? Mm-hmm. Yes, and priorities in reproductive health. Maybe you can give a chance to discuss this more. Thank you very much, if you can allow. Yes.
Sorry, I've been got off guard.
That's all right. You've been drafted.
Sorry. Sorry? Okay, I'm Dr. Nakato. I'm working at the Division of Reproductive Health. I'm the currently maternal newborn health program manager. Yes. So we were talking about guidelines. I'm not too sure what was being spoken about because I just walked in. But but yes, we have come up with quite a number of guidelines and policies, and we are reviewing the ones that have actually been a bit outdated, because we've realized that there's some of the information that we're getting, and this information is quite new and relevant to the activities being carried out at the provinces and the district level. What we're doing different this time round is, when we're coming up with guidelines, we're involving the community and also people down at the district, because initially we had issues with whatever we had come up with. Well, I don't know what the question was, but if it's about guidelines, that's what I can say for now. I could mention a few of the guidelines we have, but I don't think that's relevant for this at this moment.
I like them.
Thank you.
Oh, thank you very much, Doctor. I appreciate your being willing to be pressed into service. Would it make sense for us to take a couple more questions here in Washington? Okay.
I actually want. You're already on the spot, so I might as well just don't go.
Don't run away.
Marion Thomas, Global Network. I understand how you feel. Marion Thomas, Global Network, NICHD. We actually do some work in rural Kenya, and when you were talking about guidelines, I don't know if you're allowed to talk about it or say it, but I know traditional birth attendants doing deliveries is a big issue. So I guess officially they're not recognized by the government, but a lot of deliveries are done by traditional birth attendants. So what are you doing to impact or change those policies, if that's part of what the recent discussions you had? And if you're not allowed to talk about it, that's fine.
Okay, so you get drafted and then you get tough questions. Go ahead if you'd like to comment on that one.
Okay,
we can
fine.
just take that one by itself.
Okay, fine, no problem. TBAs, yes, traditional birth attendants are available around in Kenya, and not only in the rural areas, even in town we actually have them. And we realize that people are actually accessing this TBAs for delivery and other issues, not just delivery, also antenatal care and probably other ailments ladies have, yeah? So what we're doing about it, the government, yes, does not recognize TBAs for a number of reasons. We had tried to train them a few years ago and thought this would actually help, because we thought if mothers are still accessing these ladies and they're actually going to them for attendance, then we might as well skill them and equip them with things that would help probably with the services they're delivering. But unfortunately, this did not work as we expected. and we have now decided not to recognize TBAs at all. So what we're trying to do is to encourage the TBAs who are still in service, if I could call it that. We're trying to encourage them to send mothers to facilities early enough, and we are thinking of ways in which we can give them incentives so that when you send a lady to the facility for skilled delivery and probably other services, then we can find a way of telling you thank you and please continue with whatever you're doing, and also to talk to other TBAs, because continuing using them is actually quite an issue. But yes, it's true, we are not acknowledging them at all. But we do know that they are there. Thank you.
Okay. Thank you very much again for jumping into the gap on with no notice.
I can still take more.
Okay. Good. Well, I see some
He's
more
the
hands.
chief.
That's right. Why don't we go to Tim Thomas from Maternal Health Task Force?
Thanks, Jeff, and thank you for everybody in Kenya and on the panel on behalf of the Maternal Health Task Force who's helping to sponsor this, and my colleague Sarah Craven sitting next to me from UNFPA. We're really grateful for all your involvement in this. A couple of things I wanted to just address. First of all, on integration, there's an interesting article that just came out today in the Journal of AIDS by Lynn Friedman talking about the dangers of integration based on what John was alluding to, piling too much on the community health workers and some of this new term of isomorphic mimicry that could be the downfall for a lot of our programmatic efforts in integration, especially in service delivery. So we should all be attuned to that. What my question is, but also based on what John was talking and what Catherine was saying about the growing population cohort, especially among adolescents, and its impact on urbanization. Do we have data in Kenya that inform what this population growth is going to mean for the services needed in urban centers? Catherine, is that work been undertaken, and if so, what's that data showing, and is it informing policy? Thank you.
Okay. Actually, John, would you like to respond to that, and then we can ask them, or?
I think that certainly the data exists on what we anticipate will happen. The response in terms of investments and implementation is still unclear. I would say APHRC is particularly well positioned to help the government figure out what those scenarios might be. But I think much of the current discussion is around what do we do today? And there isn't a lot of scenario building and building back from where we'd like to be in 10 or 15 years. And I think that's a critical piece, in part because there's still a lot of political discussion about what does the government, the Nairobi City Council even, to make it very pragmatic, what does the Nairobi City Council want to do about developing infrastructure and services for large areas that would be called informal settlements? And I think that's where some of the uncertainty lies.
In Nairobi, would you like to respond to that question from the data perspective? Somebody else has been drafted.
Okay, I've been ambushed with this one, and I'll try to. Okay, my name is Andrew Imbwaga. I work with the Kenya National Bureau of Statistics. I'm a statistician, demographer. So, actually, we at the Bureau, we collect statistical information, both from surveys and also national censuses. Like just now, we have concluded the 2009 Kenya Population and Housing Census. And from these census, we have information or population by the various age groups. As you have seen or have heard, actually, Kenya, among the developing countries, our population is quite young. So we do provide this information to our sister departments and line ministries. And like currently, we are working on population projections among other population monographs that we produce from the census, and this will have or will give some informed information to the line ministries. So I'm sure we'll be able to provide information, for example, like we normally have to do some projections on population, maybe under 1, under 5, women in the reproductive age, and so on for the next 10 years before the next census. However, the challenges we have, especially with projections, is the issue of the HIV aspect. So we have to deal with some models that can help us be able to give proper projections. But this kind of information is actually what we are currently working on, and we should be able, maybe in the next 1 or 2 months, be able to produce reports that can help inform the policymakers on this. That's the much I can be able to say as far as the issue of data or population can be addressed. Thank you.
Oh, thank you. I appreciate your willingness.
Nice job.
Appreciate your willingness to step into the gap. I sense that Professor Asaji is very good at knowing who's in the room and whom to draft in on short notice.
And you work like a good team.
It's a very valuable skill. I think. Yes, please.
I just want to react to what Tim and John mentioned about overdoing integration, overloading the community health workers, and certainly I agree, and maybe that could be one research priority. What can a community health worker be able to add or achieve? But I cannot underestimate the importance of integration at different levels. When a woman have to go to multiple visits because the service is not offered during every day, or having to go to several facilities to get the visits. The missed opportunities when she's waiting for her kid to be seen and not counseling on her on PMTCT, nutrition and family planning. So I don't think we have been worked as partners and donors for years addressing our silo technical areas. We really want to reach out to work with other technical areas and look for, smart integration is a keyword. I think, thank you for saying that. Smart integration at the service delivery level, whatever level, funding level, policy level, definitely, because they interact and some policies can't contradict if we're not putting them all on the same table. Sorry, I'm looking this side. I should be looking this side. And definitely for the community level, it's a big question, and maybe that would be one research topic that we have to invest more in Kenya and other countries. Thanks.
I'd just like to add that some integration is absolutely essential. For example, 18% of the maternal deaths in many countries in sub-Saharan Africa with endemic HIV are due to HIV, and AIDS. So, we can't address a significant proportion of maternal deaths without actually thinking about it in a way. And we have models around the prevention of maternal-to-child transmission that are highly effective, but they just aren't implemented. So they're available to fewer people. And if you think we have weak hospital systems, doubling or tripling the number of people without actually increasing improvement in the quality and number of staff, the capacity for C-sections, or the capacity to provide maternal health pharmaceutical products like magnesium sulfate or misoprostol, boy, we're looking for problems. At some point, you can push this, but then you have to figure out at what level is the system prepared to provide this care. So we have to think about the end game and build back our capacity and investments to make sure that happens.
Did you have a follow-up for that, Tim? And then we have a question over here.
Hi, Jeff. Thanks. The article I'm referring to talks exactly about that, John. It's Lynn Friedman in the Journal of AIDS today. And it talks about persistent implementation failure in integration. We have policies, we have models, but maybe exactly what you're talking about, Nahid, exactly right, and maybe Kenya's the place to do this. Some operations research on how integration is and is not working. And what can we learn from that, especially given that the enthusiasm and overabundance of money in HIV/AIDS versus the maternal health and maternal neonatal health interventions. So I don't think anybody's saying we're not calling for integration. It's this idea of smart integration and how we overcome persistent implementation failure is the goal here. That's just a clarification. Thanks, Jeff.
That's terrific, Tim. Thank you. Ma'am, been very patient in the back there. Please.
Hi, my name is Erica Larson from Population Action International. And I'm actually pleased that this is centered around integration. It's almost like this session should have been called something about integration, maternal health, reproductive health. I wanted to shift back to the Kenyan colleagues. Kenya has been a leader in integration, especially with reproductive health, HIV, and maternal health. So I wanted to hear, I know Kenya has really good integration policy, but kind of what the barriers have been in implementing that policy. Also, as a U.S. advocate, I'd like to hear what U.S. policies you would like to see changed to kind of support meaningful integration at the country level. And finally, I'd like to hear more about if the new Kenyan constitution and the model of decentralization will affect the way that these integrated services will be delivered.
Okay, so you managed to get 3 good questions in there.
Very good.
Decentralization, advocacy on the U.S. side to help the Kenyan side, and the first one was the model barriers to integration given the leadership position they have there. Would someone in Kenya, then who is Jeff drafted to answer this one? Go ahead, Catherine.
Okay, I'll take a shot at that. And we had a discussion actually in the group where I was about, it was still linked to the issue of recruitment and retention, because I think there are good intentions in terms of integration, but then the people that are expected to integrate are not, the number is not increasing. So the same midwife is supposed to integrate like 7 different tasks. And in most cases, especially at the primary health care level, you find it's the same midwife that does the maternal health services, is the one that does the child health services and does the adult health services and everything else, and manage the system and the health information. So I think it's the intentions to integrate are there, but then the commensurate levels of health workers have not been put in place. And one of the things that we discussed was the fact that if integration happens even at the funding level, at the budgeting level, at the planning level, then some of the funds, for instance, that are being spent on in-service training could be diverted to pre-service training so that we have more midwives. Because apparently, even the schools that train midwives, some of them don't even have the capacity to train as many midwives as they want because they're small. And even when they have the capacity, then access to that is limited because government can only give so many scholarships. So, I mean, if there's real political will at all levels to integrate, I think even the funding mechanisms could be done in such a way that part of the money that is planned for in-service training can be taken to pre-service training. So you have more midwives, and then they can start integrating. But right now, I agree that it's too much to expect that one midwife is going to have all these integrated services and manage to do them successfully. So I think some of the barriers are the fact that the human resources in terms of numbers are still low, and therefore integration perhaps with all the best intentions is not as successful as it should have been.
Terrific. Would Catherine, would you or one of your colleagues like to take on what kind of suggestions you might have on the U.S. policy side for those in the audience here who are on the advocacy side? They're, of course, interested in getting your feedback on what would be most useful in terms of either strengthening or changing from the policy side on the U.S. Policy side, and then the other question of the potential impact, if any, of the Constitution and decentralization.
I'll take a shot at the first one. I think there's a lot of good intentions about systems strengthening, and my personal view is that integration should be part of a whole system approach. And still, much as there's a lot of talk and intentions about system strengthening, it is still system strengthening for women, and then system strengthening for children, and then system strengthening for people with HIV, which I think in my view is perhaps going it the wrong way. A system is a system, so trying to advocate for a system and then strengthening little bits of it, then it defeats the whole purpose of what a system's approach is. So I would advocate for strengthen the whole system for everybody, and the women will be taken care of, the children will be taken care of. But I think it's a bit of a contradiction to try to strengthen the system and then say, actually, we're strengthening it for the women and the children. and then somehow somebody else will strengthen it for the older people and the men, and somebody will do it for the adolescents. I think that's where perhaps the problems come in. In terms of the decentralization, I don't know where Professor has gone. We need to co-opt somebody here. Chacha. Yes, I don't know. My understanding of it is that it's still work in progress, trying to sort out the systems, the allocations, the funding mechanisms, the regulatory framework. So I think it's still work in progress that perhaps maybe in the next couple of years will be sorted out. But I expect that perhaps decentralization in other countries has improved efficiency, but decentralized corruption and all that. But somehow, I don't know. Okay, Ikamari wants to take over.
I don't know. The issue is that the Constitution Implementation Committee is still working on these issues. Issues to do with how to operationalize these devolved structures. And it's only after the necessary legislation has been put in place that we can assess the likely impact on delivery of various types of care at the community level. But as of now, the intentions are there as contained in the recently adopted constitution. So a lot of work is going on currently to translate, to bring in legislation that will see some of these things really have effect, on the ground. And we have to give it some time before we can see what the legislation will mean in terms of service delivery. Thank you very much. Unless somebody from the audience wants to add. Thank you.
I'm going to make a special request. There was a presentation here on the human rights dimensions of the maternal and child health, and I feel it will be inadequate for us to conclude the discussions without giving the expert in that area 1 minute to comment on what the findings he has done reflect, and the recommendations he has also given.
Terrific.
So, if your permission, I can give her a minute to comment on it.
Please, please, thank you.
Introduce myself. Okay. Is it? I don't know what time it is in America. Is it morning?
Almost lunch.
I was going to say, this is good evening. I'll say what's in Nairobi. It's good evening.
That's fine.
Okay. Well, I just wanted to divert a little. For the past 30 years, we've been looking at maternal health as a disease in terms of clinical, medical approach. But I feel it's time to move to look at human rights, gender, culture. Somebody mentioned it. We've never looked at it that way. To bring that at a point, the magnitude, us losing 8,000 mothers per year, when we compare this to deaths in Iraq, that's a war zone, deaths in Somalia, they lose 10,000 people, men and women, and 9/11, I think we lost quite a number of people, around 3,000 to 4,000. In Kenya, we're at peace. We lose 8,000 mothers per year. Then you wonder, our labor boards, are they war zone? Because soldiers are not dying in the barracks. So that's why we must bring this attitude, this magnitude to policymakers, to Ministry of Finance, citizens, and the development partners, the international world, so that the magnitude of mothers dying voiceless in labor ward is brought to the forefront. So the 8,000 deaths, if we call a plane of 100-seater, that would be 80 planes crashing. And if we look at a minibus, a 10-seater minibus, that would be 800 minibus full of pregnant mothers crashing and nobody surviving. That's the magnitude. And I remember in Kenya, we had a disaster where we lost 200 people. We had a petrol tank and a fire in a supermarket. We lost 200 people. And we were given 5 days of mourning, half-mast. And if we say for 8,000 mothers, we need 200 days. Is it 6 months of mourning? And you can imagine what it does to production, what it does to economic. I mean, we must bring that to that level for policymakers, for politicians to take it seriously. And I forgot to introduce myself. Okay. Sorry. I'm Dr. Margaret Nene. I was working in the Ministry of Health before, but now I'm doing consultancy work in gender and maternal health. So when we look at, somebody mentioned gender inequalities around maternal health, and we can look at this. I had a slide at my presentation. I know at family planning, it's mostly the burden of a woman, so there's that inequality. But we know at conception, there is gender equality there. We need both man and woman. But then later on, the burden is taken by the woman because she's the one with the uterus. She goes to labor ward. She gets complications. She dies. But unfortunately, when the woman dies, the man is called to identify the body, to take the body home, and then to bury. And the grave is done by the young men of the village. So you can see, women can be, they are affected, they're infected. And the men are the affected, but we have no programs for them. So we need that male involvement to help us to make them dig less graves.
Here. Very good. Yeah, thank you very much, ma'am, and thank you for bringing that critically important perspective to the discussion, and that the importance of the magnitude of the problem. Even as Jane Harmon said up front, even though we have made significant progress, it's nowhere near enough. And so thank you very much for bringing this perspective forward. Do we have other questions here, or I should say, are there questions in Nairobi that folks there would like to pose to panelists here, or in response to some of the comments? We do have one here. Why don't we take that? But I want to be sure that Nairobi has a chance to pose questions. Ma'am, please go ahead.
Hi, I'm Elizabeth, and I'm representing Result Educational Fund. I was just curious to know if Kenya is looking towards any type of research needs in the area of tuberculosis comorbidities with HIV, since a lot of people die from TB complications rather than HIV, and also if they've looked towards the issue of food security related to those issues, since at least some of the articles that I've read in other areas in sub-Saharan Africa, they're now looking towards increasing the agricultural sector and traditional wild foods, which help alleviate the food scarcity issues that prevent people from going through with HIV/AIDS treatments.
Okay, we've talked about some of the integration. Malaria came up, but also TB. Is that something folks here, or?
I think that's I mean, they clearly are doing it. This is a very skilled, community in Nairobi.
Folks in there perhaps want to expand on the connections with agriculture, but also then TB was mentioned, or TB was asked about. We've talked about malaria and some of the others, and integrating to some of these other diseases. Are there research or work in these areas that you'd care to comment on?
Probably I'll not highlight on that last request. Dr. Mukaindo Abraham. I'm an obstetrician gynecologist working in a private hospital in Nairobi. Probably the important issue I would like to highlight is the issue of community involvement, either in private and public integration, especially in the issue of transport in terms of referral. These are successfully, a model like this has been implemented in other countries in the region. For example, in Ghana, they have tried the issue of tractor motorcycle referral, which is something that probably can be worked with in conjunction with the donor community and also the communities that they take up ownership of that. In addition to that is the issue of insurance, community insurance in health Some studies have gone into this, and in Rwanda it tended to increase uptick of maternal delivery, health deliveries in hospitals. So this is an issue that probably can be addressed more. The other issue is the issue of autonomy, that many of the health facilities may not have the autonomy either to channel resources or to make decisions that affect populations at that level. A case in point during the discussion was whereby a medical officer in charge of a district hospital may have the resources from the collections, but the vote is exhausted for fuel, and therefore they may not be able to have the autonomy to decide to take the patient to another level, as well as the authority to reward or punish, behavior among the health workers. So those are some of the issues I think may be addressed a little more. Thank you.
No, thank you very much. And in fact, I would highlight as a way to connect to some of the previous meetings we've had here, your point, very important point about transport was the focus of a day-long workshop in the previous session of the maternal health series. And I should say the PowerPoint slides and the reports and the video from that meeting, as well as all the previous meetings, are on the Wilson Center website, and we hope those will continue to be resources for folks here and folks in Nairobi, because I think you flagged some critically important questions. Are there other questions or comments?
I want maybe to react about TB and integrating maybe the experts in the audience. They are not there, but through the USAID Global Health Initiative, all those technical areas and support is actually recommended to be integrated, and opportunities to. I'm not familiar of the TB program funded by AID in USAID, but that's a standard policy that when developing the Global Health Initiative, all the different technical areas and different U.S. agencies, not only USAID, would come together to work with the ministry on developing this program. Thanks.
Yes, I see we have a new draftee there in the chair in Nairobi.
Yeah, I'm here as a volunteer rather than a draftee. Tony Daly, I'm the Regional Maternal Health Advisor for DFID based in Nairobi. I just wanted to pick up and emphasize a couple of points mentioned almost in passing by some of the panelists. One is on advocacy. Looking back at history, whether it's Europe or other Asian tigers or other countries, maternal mortality has been reduced within a decade or two, which is as fast as we can expect, a significant reduction in maternal mortality, through two things. One is political will, and the other is good use of data. And they're obviously mutually reinforcing. Data can be used to identify the scale of the problem, but also to identify how to improve it. Sometimes data has been generated very much to create political will, but the political will part of it is often missing, and we need to think carefully about how we can create the political will through targeted and strategic advocacy and accountability, and then to continue supporting that with good data. I think linked also to evidence, one of the things that I've noticed, when we have successful projects, the outcomes, outputs, impact are widely disseminated, but rarely do we know at what cost. And therefore, it's very difficult to make a judgment when you have resources on whether to fund something, because you have to know what your likely impact is with the resources you've got. So we need to very much look at how much it costs per outcome achieved and what the cost is to go to scale. And if it's not affordable to go to scale, then we need to look again at what interventions that we need to try and develop. So there's lots happening. It's a very innovative sector. Lots of opportunities with mobile technology, but we need to keep coming back to what it costs. The other thing is, I think it was invited that we give some suggestions on policy, and I think some ideas of policy for all donor agencies, not my own or the US, is striving to achieve results. Obviously, focusing on what we achieve is very important, but a policy shift in USG support is also on how, and I think we all need to learn lessons on how. And we talked about incentives earlier within the public sector, but incentives among our implementing partners are also important. So one thing that sometimes works is when you're contracting an implementing partner to promote a kind of 360-degree feedback where a key item on the log frame or a deliverable is key implementing partners, for example, government, view the project as being supportive and flexible of their policies. And I find that's worked very well with implementing partners at the project level, and something I'm promoting we all adopt. Thanks very much.
Terrific. Thank you. Thank you for those additional points. I think we've come to the end of the time. Is there a final word from Nairobi to wrap?
Thank you, Geoff. We have enjoyed this session. It has been a very productive, interactive session for us, and we are also trusting that Washington has equally benefited from it.
Hear, hear.
The results of this particular discussion are going to be captured in our report, which the APHRC will share with you. And tomorrow we are still sharing the results of this particular discussion today with policymakers, whom we will be meeting very early in the morning. And I believe that in due time, you'll hear from us in terms of how the policymakers reacted to this particular discussion. Thank you.
Well, Professor, thank you for so ably bringing so many of the experts there in Nairobi into the discussion. That was tremendous to have both you, the speakers, but then also these additional points that really captured the expert analysis on the specific questions we had and brought these additional perspectives to bear. Thank you to John and Etta for your comments and presentations, bringing that. Thank you for some excellent questions here. And I should really say thank you to the African Population Health Research Center for being such an excellent collaborator and partner. And I know you've had a tremendous meeting today, and we look forward to hearing about your meetings tomorrow with the policy community. I should say that the video and the meeting reports and the advanced papers and the summary papers from this meeting will all be available on the Wilson Center website. We'll share that with you going forward. We ask you to also look for the future meetings in the maternal health series, the ones held here in Washington, and then, as was referenced, another one with this partnership coming from Nairobi for the fall. So from Washington, a very great thanks, and thanks for staying late tonight. I know it's on into the evening for you, and we appreciate it very much, and best of luck with your meeting, and thank you very much for sharing your expert insights with us today. So thank you.